This conference will now be recorded.
Today's topic is about abortions and its management. Coming to the definition of abortions, it is also called as miscarriage, and these both terms are usually interchangeable, and most of us will prefer miscarriage for a spontaneous loss. And this it is defined as spontaneous or induced termination of pregnancy before fetal viability, that is after 20 weeks, and weight of the baby should be more than 500 grams, should be less than 500 grams, and it should be below 20 weeks of gestation. And early pregnancy loss, it is defined as a non-viable intrauterine pregnancy with either an empty gestational sac or gestational sac containing an embryo or fetus without fetal cardiac activity. And this should be within first 12 weeks, that is less than 13 weeks of gestation. The next thing is a pregnancy of unknown location. It is nothing but the pregnancy is confirmed by beta HCG. I mean, it is identified by beta HCG, but no sonographic confirmation is there. Then we'll call it as a pregnancy of unknown location. And the next is a recurrent pregnancy loss or habitual abortion. It is defined as a consecutive loss of 3 or more pregnancies. And the next definition is a induced abortion. This is medical or surgical termination of pregnancy before the time of viability. So these are all definitions. Coming to the types of abortions, spontaneous abortions and induced abortion. Spontaneous abortion, it includes threatened abortion, inevitable abortion, incomplete abortion, complete abortion, missed abortion, and septic abortion. We'll discuss these all. So first trimester spontaneous abortion, more than 80% occurs within the first 12 weeks of gestation, and the main pathophysiology behind this is the death of the embryo or fetus. This will always precede the spontaneous expulsion. So the embryo which is not having intracardiac activity, they'll go for a spontaneous expulsion. After death, there will be hemorrhage into the desicca basalis, and it leads to adjacent tissue necrosis. This necrosis, it will stimulate the uterine contractions, and this leads to expulsion of the fetus. So coming to the incidence, generally it is between 5 to 20 weeks of gestation. The incidence will be around 11 to 22%, and this is higher in early weeks of gestation. And coming to the factors which cause abortion, fetal factors, this can be either anembryonic pregnancy or embryonic pregnancy. Both comprise 50%. And in embryonic pregnancy, it can be either aneuploid or euploid. In aneuploidy, it is 25%, and the most common will be the trisomies, and monosomy chromosomal abnormalities are also common. And in euploidy, this comprises of 25% of abortions, and the chromosomal pattern will be 46x6 or 46x5. Some pathology will be there. And in euploid abortions, the peak abortion rate will be at around 13 weeks of gestation. And coming to the anembryonic factors, that is blighted ovum, the mean gestational sac should be more than 20 mm with absent embryo. And the fertilized ovum implants, but embryo does not develop. So this is anembryonic pregnancy. Coming to the aneuploidy abortions, the most common in early gestational age, and 75% occurs by 8 weeks of gestation. And among these, 95% will be maternal gametogenesis defects, and 5% will be the paternal errors. Among the aneuploidy abortions, the most common chromosomal anomaly will be the autosomal trisomy, either 13, 16, 18, 21, or 22. Any of these trisomy patterns may lead to aneuploid abortions. And the next is a monosomy X, the single most frequent specific chromosomal abnormality, that is 45X4, that is Turner syndrome. And the next will be the structural abnormalities. These infrequently cause abortions, and with gestational age, there will be more rate of anomalies and more rate of abortions. Coming to the euploid abortions, as we already discussed, these are peak at 13 weeks of gestation, and the incidence of euploid abortions will increase with maternal age, that is more than 35 years of maternal age. And this is the fetal factors. Next, coming to the maternal factors, any infections like viral, bacterial, or any other infectious agent which invades a normal human being can cause pregnancy loss, and many of them are systemic and infect fetoplacental unit by blood-borne organisms. And the next, either a local infection can also lead, that is either genitourinary infection or colonization in the urinary system may lead to abortions. Among the aborters, almost 4% of them have been infected with chlamydia trachomatis, and periodontal diseases, polymicrobial infection from periodontal diseases. This also leads to 2 to 4-fold increased risk of abortions. The next is the bacterial vaginosis. This has a more association in second trimester than in first trimester compared to other vaginal infections. Next, coming to the medical disorders which affects mother and which leads to abortions. Generally, early abortions are rare due to chronic wasting disease like tuberculosis or carcinomatosis. And most common diseases which leads to abortions are diabetes mellitus, thyroid disorders, celiac disease, eating disorders, or any heart disease complicating pregnancies, SLE, IBD, chronic hypertension. In all such conditions, there will be a high rate of abortions. Coming to the diabetes, those patients who are having optimal glycemic control, they can prevent the losses. But generally, patients who are having a peri-conception glycemic level abnormalities or any abnormal metabolic control, in such cases there will be more malformations and more rate of abortions will be there. And next is the thyroid disease, either subclinical or autoimmune, subclinical hypothyroidism or autoimmune Hashimoto's thyroiditis, or those having antibodies to thyroid peroxidase of thyroglobulin levels. In all such conditions, there will be increased risk of abortions. Next, celiac disease. Both this leads to, in general, preconceptional only. Both they may land up in infertility, and the other will be cyanotic heart disease, eating disorders like anorexia nervosa, bulimia. These all are related with the subfertility and will be decreased fertility rate. And if they got pregnant, they'll land up in a preterm delivery or fetal growth restriction, and abortion rates are also higher. And the next is SLE, IBD, and chronic hypertension. In all such cases, there will be increased risk of recurrent miscarriages. And coming to the medications, few medications have been evaluated in the role of pregnancy loss. And apart from this, IUCD insertion, those who have conceived with IUCD in situ have increased risk of abortion. And most commonly, septic abortions are the most common with this IUCD. And next, coming to the cancer therapy, those who are having a radiation and chemotherapy, they have a more, the drugs may cause abortions. In radiation, therapeutic doses are abortifacient, and less than 5 rats, they does not have an increased risk of abortions. And if more than 5 rats, they'll lead to abortions. And coming to the chemotherapy, effect in causing abortions is not well defined. With methotrexate, malformations are seen along with spontaneous abortions. This is the only proven drug. And the next is the surgical procedures. Generally, if the antenatal mother, if she's having any surgical procedures, if they're uncomplicated, there will be no risk of having abortion. But in some cases, they may land up in abortions. If a mother is if she's 6 to 8 weeks pregnant, then a single dose of 150 mg intramuscular injection of 17 hydroxyprogesterone caproate is sufficient, and it is given at the time of surgery. And if the mother, she is 8 to 10 weeks of gestation, then we have to give 3 injections at the time of surgery, and after 1 week second dose, and then after 1 week a third dose should be given. Along with this, oral tablets of progesterone should be continued until 10 weeks of gestation. And the other factors, social and behavioral factors like alcohol, smoking, and excessive caffeine, these are all related with increased risk. Caffeine, if excessive intake, that is 5 cups of coffee or 500 mg of caffeine, this slightly increase the risk of abortion. And if it is a moderate, that is 200 mg daily of caffeine intake, there will be no risk. The other factors will be occupational and environmental factors. Chemicals like arsenic, lead, formaldehyde, benzene, ethylene oxide, DDT, all these are involved some way. These are all related to the increased risk of abortions. Next is the immunological factors. APLA, as we all know, APLA is the most common immunological factor which leads to abortions, recurrent pregnancy losses. This has to be evaluated with either lupus and testing of lupus anticoagulant or anticardiolipin antibodies and anti-beta 2 glycoprotein 1. These levels should be checked, and then we can come to a diagnosis whether APLA is there or not. And the thrombophilias, like antithrombin 3 deficiency, protein C, S, these are associated with first and second trimester losses. The next factors are uterine synechiae, like Asherman syndrome. If these are nothing but adhesions in the endometrial cavity, this image it shows the adhesions in the endometrial cavity. Scar tissue is there. So in such conditions, the embryo cannot get implanted, and this leads to abortions. And the next is a uterine leiomyoma. The site is more important than size. If the leiomyomas are present in the either intramuscularly, which embed the endometrium, or if they are present in the submucosal layer, then they are more associated with abortions. And congenital genital tract anomalies, abnormal mullerian duct formation or abnormal fusion like bicornuate, unicornuate, septate uterine, in all such conditions, there are more chances of abortions. Next is the paternal factors. So far we have discussed about the maternal and fetal factors. Now this is a paternal factor. The most common cause will be the chromosomal abnormalities in the sperm and increased paternal age. These are more related to abortions. So these are all the factors which leads to abortions. Now we'll discuss about types of abortions. First, we'll go with threatened abortion. This is nothing but the pregnancy is intact, but there is obvious risk to its continuation. So bleeding will be there. The patient will present with a bleeding, and it is followed by pain. In such cases, first we have to rule out the ectopic. In ectopic, the patient will have pain, and then followed by bleeding will be there. Coming to the examination, this is generally not required unless bleeding becomes heavy or if a pain is more. In such cases, we'll do a PV examination. In the findings will be uterus will be soft corresponding to gestational age, and the internal loss will be closed in threatened abortion. And on speculum examination, to exclude the local pathology, polyp, erosion, and rarely malignancy, these all should be ruled out before coming to the diagnosis of threatened abortion. So coming to the investigations, first we have to confirm the pregnancy, that is beta HCG should be done. If it is an intrauterine pregnancy, the serum beta HCG increases almost it doubles in every 48 hours, and then serum progesterone levels should be done. If it is a more than 20 nanograms per ml, it indicates a healthy pregnancy, and if it is less than 5, it indicates a dying fetus. And then we have to confirm with a sonography, that is TVS should be done to confirm the pregnancy and to confirm the viability, and then depending upon the amount of bleeding, we can go with the management. So in scanning, generally these are the findings in ultrasound. This is a TVS and this is a TAS. Uh, Around 4.5 weeks we can see a gestational sac, and around 5 weeks we can see a yolk sac, and around 6 weeks we can get a fetal cardiac activity. And beta HCG levels, in all such conditions, the beta HCG levels will correspond around 200 micrograms per international unit. And this is the TAS. In TAS, we'll see the gestational sac 1 week later to the TVS form. So this is the threatened abortion signs, symptoms, and how do you manage. As we already discussed, in a threatened abortion, the cervix will be closed and the fetus will be viable, and the uterine size, it will correspond to your gestational age, and there will be minimal bleeding and minimal pain. And then we'll go with ultrasound for viability, and we'll go with a vaginal examination. And coming to the management, there will be no specific management. We have to wait and watch. Inevitable abortion, it is a clinical type of abortion where the changes have progressed to a state from where continuation of pregnancy is impossible. So it will expel. So we'll have a bleeding, and then we'll have uterine contractions which are painful. This leads to cervical dilatation, and then gross rupture of membranes, and then followed by expulsion of the fetus. On examination, the uterus will feel it is soft and enlarged, and generally os will be open and products can be felt through os. In inevitable abortion, the cervix will be open, bleeding will be seen, but no passage of products of conception will be seen. There will be abdominal pain, and uterine size is equal to the gestational age. We'll go with the general investigations, and we have to monitor her vitals because to rule out infection, and any shock should be ruled out. And the next is a management. Either we can go with expectant management, medical management, or surgical. Expectant management, it is nothing but we have to wait, and progesterone supplementation can be given. And medical, in inevitable I mean, we have to wait and watch and expectant, and we have to see for spontaneous expulsion. In medical management, we can go with either mifepristone or misoprostol depending upon gestational age, and in surgical, we can go with dilatation or curettage or any amniotomy or any other procedure can be done. In incomplete abortion, this is the entire products of conception are not expelled. So some parts of the products of conception are left inside the uterine cavity. It is called as incomplete miscarriage or incomplete abortion. In such conditions, generally in incomplete mid-trimester abortions, placenta may sometimes be retained, and then we have to start oxytocin infusion at a rate of 10 to 20 units in 500 ml of dextrosaline, and then followed by evacuation of the uterus as early as possible should be done. And the next is a complete abortion. When products of conception are expelled en masse, it is called a complete abortion. There will be history of heavy bleeding per vaginum, cramping pain will be seen, and passage of tissue or fetus will also be there. And we have to confirm it with beta HCG and ultrasound for evidence of complete expulsion of products of conception. And it should be ruled out with ectopic pregnancy as the uterine cavity will be empty. So we have to check for ectopic pregnancy. And the next is the missed abortion. Dead products of conception that were retained for a days, weeks, or even months in the uterus with eclosed cervical loss is called a missed abortion. A mean death to abortion interval will be approximately 6 weeks, and it is also called as early pregnancy loss or wastage. And this should be differentiated with a blighted ovum, where the mean gestational sac will be more with the absent embryo. And the standard treatment will be surgical evacuation using suction curettage, and expectant management will be it will completely abort within 14 days, and we'll see. And those mothers who are having a negative blood group, that is Rh negative pregnancy, then we have to give her anti-D immunoglobulin. If it is a spontaneous abortion, then I mean, if it is less than 12 weeks, then we'll give a 50 mcg or intramuscularly. If it is more than 13 weeks, we'll go with 30 micrograms of anti-D. Next, coming to the medical management of these abortions, most commonly we'll use a misoprostol, either single or multiple doses, and 70% success rate will be seen with the misoprostol. And mifepristone can be used alone or in combination with misoprostol. So this is a table. These are the signs and symptoms of abortion, various types of abortions. In threatened abortion, the most common thing will be the most salient feature will be that there will be a closed cervical loss. In other things, inevitable abortion, incomplete and complete abortion, there will be dilated. And in complete abortion also, as the patient has expelled completely, there will be closed os. But the history she'll give a history of a passage of tissue or clots previously. So this is nothing but the image. And next is a blighted ovum. The fertilized ovum whose development is arrested early in the pregnancy. This is called as a blighted ovum. And this is the cause of 50% of first trimester abortions is a chromosomal abnormalities, as we already discussed. And coming to the ultrasonic features of the anembryonic gestation, yolk sac will be absent, and the means in TVS the mean sac diameter should be more than 13 mm, and in TAS the mean sac diameter should be more than 20 mm. And if embryo is absent, then the mean sac diameter should be more than 16 mm and mean sac diameter more than 25 mm should be there to confirm a diagnosis of blighted ovum. So this is all about blighted ovum. Next, we'll discuss about recurrent miscarriage. This is also called as recurrent spontaneous abortion or recurrent pregnancy loss or habitual abortion. And coming to the definition, it is consecutive loss of 3 or more pregnancies at or less equal to 20 weeks or with a fetal weight less or equal to 500 grams, then we'll call it as a recurrent miscarriage. So 3 or more pregnancies should be there, should be considered before coming to a diagnosis of recurrent miscarriage. Subsequent rate of rise of miscarriage rate will be generally in a first time there will be 7% loss of pregnancies, and first pregnancy loss it is around 14%, and if she is having a previous one miscarriage, then there will be 26% of chances for next pregnancy loss, and then in third pregnancy it will be around 28% of chance for a miscarriage. The next is a non-consecutive miscarriage showed some pattern of risk as consecutive miscarriages, and successful chance of successful pregnancy are more than 50% even after five losses. So coming to the etiology of this recurrent pregnancy loss, it can be either parental chromosomal abnormalities or APLA or any uterine abnormality. In all such conditions, these are the most common causes of a recurrent pregnancy loss. So these are the tests used to evaluate a couples with recurrent pregnancy loss. First, we have to go with the chromosomal abnormality. That is, genetic testing should be done. That is, karyotype of both partners should be evaluated, and then followed by counseling to the both parents. And if required, we have to go with the donor gametes. And if she's having any anatomic defects, that is any uterine anomalies or anything, then we have to confirm the diagnosis with a sonohystrography or hysterosalpingography or MR imaging. And then if she's having septate uterus or any fibroids or anything, then we'll go with a septum transection or myomectomy or edisolysis. And then immunological, that is APLA. We have to test with the lupus anticoagulant, anticardiolipin antibody, and anti-beta-2 glycoprotein antibodies. Then we'll go with the treatment, that is heparin, low molecular weight heparin, and followed by aspirin. And along with that, aspirin should be given. And endocrinological causes that can be either, as we discussed, it can be thyroid or any prolactin releasing tumors, or if the mother is a diabetic or any other abnormalities, these all can lead to recurrent pregnancy losses. In all such conditions, we have to give um, uh, the treatment. If she's having any subclinical hypothyroidism, then we'll go with the levothyroxine. And if prolactin levels are raised, then we'll go with the dopamine agonist. And if she's diabetic, then metformin or insulin can be given. And any mid-luteal progesterone phase defect, then we'll go with the progesterone supplementation. And these are the other causes, that is thrombophilic causes, protein C, S deficiency, factor V Leading mutation, antithrombin deficiency. In all such conditions, there are no proven treatment therapies. And the next is the toxic causes, tobacco, alcohol use, and toxins, exposure to toxins, chemicals. In all such conditions, we have to avoid consumption, and we have to maintain our behavioral modification should be done, and weight loss should be maintained. So treatment for recurrent pregnancy losses, as we all know, this the most common cause will be cervical insufficiency. The cause will be in second trimester. The cause will be the cervical insufficiency, and in such cases, we have to go with the cervical encephalus at 14 weeks. And the most commonly used cervical encephalus will be Shirodkar and McDonald. In Shirodkar, this will involve the dissection of bladder and application of stitch at the level of internal os. And in McDonald's also, it will go with a purse string suture. That is, we'll take a 4 bites and we'll suture it as a purse string method. The next is a mid-trimester abortions. We have discussed so far early trimester abortions, and now mid-trimester, that is in second trimester, from the end of first trimester until fetus weighing 500 mg and gestational age reaches 20 weeks, that is up to viability. We'll call it as a mid-trimester abortions. And the incidence, it becomes less common with increasing in gestational age, and up to 16 weeks, it is 1.5 to 3%, and it is 1% greater than if it is more than 16 weeks, then it will be more 1%. So causes of the mid-trimester abortions, they can be due to fetal anomalies, uterine defects, and placental causes, and maternal disorders. In fetal anomalies, it may be due to chromosomal or structural abnormalities. In uterine, it can be either due to congenital anomalies in the uterus or any leiomyomas or incompetent cervix. In placental causes, it can be either due to abruption or previa, or any defect in the spiral artery transformation, or any infection, that is chorioamnionitis. In all such cases, we'll have a mid-trimester abortions. And maternal disorders like autoimmune infections and metabolic, like diabetes, thyroid, all these conditions can lead to mid-trimester abortions. Fetal and placental evaluation. If a woman with more than 35 years, the risk of 85% of chromosomal abnormalities will be there, and 13% of fetus will have some malformations. Can I continue the class? In septic abortions, any abortion associated with clinical evidence of infection of the uterus and its contents, it is called a septic abortion. And the cause may be due to either retained products of conception or incomplete spontaneous abortion or therapeutic abortion or any illegal abortions which were done by RMPs or anyone. In all such conditions, there will be evidence of infection to the uterus and it leads to septic abortions. Coming to the pathophysiology, it begins as endometritis and 80% involves endometrium. And it is not, if it is not treated, then it will spread to the myometrium and parametrium. And this finally may land up in peritonitis and the patient will have a septic shock. Coming to the incidence, deaths due to unsafe abortion remains close to 13% of all maternal deaths, and 86% of abortions takes place in the developing countries. And coming to the signs and symptoms, most of the patients will have fever that is more than 38 degrees for at least 24 hours, and they'll have offensive or purulent vaginal discharge, and they'll have a lower abdominal pain, tenderness, and mass may be seen, and the patient will have a tachycardia that is more than 100 beats per minute, and there will be a positive pregnancy sign. If a patient is having a septic shock, then she'll have a tachypnea, tachycardia, hypotension, hypothermia will be there, and oliguria and sepsis symptoms and signs will be seen. And next, investigations of septic shock, septic abortion. Routine investigation should be done like blood grouping typing, and then total counts should be done. Urinary routine should be done, and then cervical and high vaginal swab to be done to know the cause of organism. Which organism has caused the infection, and then special investigations like ultrasound. This is to rule out the retained products of conception, pyometry, and any free fluid in the POD, and blood culture should be done, followed by electrolyte levels in CRP, and coagulation profile, plain X-ray abdomen and chest should be done to rule out peritonitis. Coming to the complications, immediate complications, there will be hemorrhage and injury to the uterus. When we are doing any, as there is infection in the uterine cavity, it will be very friable. Then if we are doing any dilatation and curettage, then there will be injury to the uterus. And this is followed by generalized peritonitis and endotoxic shock, acute kidney injury, and thrombophlebitis. These are the immediate complications. And remote complications will be the patient will land up in a chronic pelvic pain, and she'll have a dyspareunia, and ectopic pregnancy in future she can have ectopic pregnancy, and due to infection there may be formation of the adhesions and scar tissue will be there, so she may land up in infertility due to Asherman's, and she may have emotional depression. So coming to the principles of management of septic shock, first we have to control the sepsis and remove the source of infection. Then along with this, we have to give a supportive therapy to bring back to the normal hemostatic and cellular metabolism. And then we have to assess the response to treatment. Then we have to change the management. So coming to the grading management, if grade 1, it is in grade 1, it is the infection is localized to the uterus, and coming to the management of grade 1, we'll give antibiotic treatment depending upon the sensitivity, and the prophylactic anti-gas gangrene serum can be administered, and anti-tetanus serum should also be given. And if she's bleeding, then we have to give her a blood transfusion depending upon her hemoglobin levels, and then this should be followed by evacuation of the uterus. And in grade 2, the uterus, tubes, ovaries, parametrium, and pelvic peritoneum, all these are involved, and along with the grade 1 management, we have to evacuate the uterine cavity after 48 hours of antibiotic therapy, and if required, we have to go with the posterior colpotomy, and we have to monitor the vitals. And grade 3, there will be endotoxic shock and generalized peritonitis will be seen, and she may have a jaundice and acute renal failure. In all such conditions, we have to give antibiotic management, and we have to monitor the patient. ICU management should be given, and if required, active surgery should be done. If there is any, if it is unresponsive peritonitis or any collection of the pus, we have to open abdomen and we have to drain. And the next will be the induced abortions. It is induced abortion. It is defined as a medical or surgical termination of pregnancy before the time of fetal viability, and 66% of pregnancies aged less than 6 weeks have landed up in induced abortions, and 92% of abortions completed less than or before 13 weeks they'll have induced abortions. And in India, the MTP Act, it was adopted as a health measure in 1972 to avoid death due to criminal abortions. So these are all regimens for the medical termination. Either we can use a mifepristone or misoprostol. Generally, we'll have an MTP kit, that is mifepristone 200 mg, and misoprostol we have a 4 tablets of 200 micrograms. These can be taken either orally, vaginally, or sublingually, and either it can be given immediately, or after 72 hours we can give this misoprostol. So where all we can go for MTP, that is what are the indications? The conditions like medical conditions or eugenic conditions or humanitarian or social, in all such cases we can perform an MTP. Medical conditions, the continuation of pregnancy, which if it endangers the life of pregnant women, then we'll go for a MTP. And or any grievous injury to her physical or mental health, like severe hypertension, cardiac disease, diabetes, psychiatric illness, any cancers, in all such conditions we can go for a induced termination of pregnancy. And eugenic conditions, that is if it is a malformed embryo that we have, if we are suspecting any chromosomal abnormalities or anything else, then we can go for a induced abortion. And if humanitarian grounds, if the pregnancy it has been due to rape or incest, then we can go with a induced abortion. And social causes, it is a failure of any contraceptive device, we can go with the MTP. So where can we perform MTP means any hospital established and maintained by government, or which the place which has been recognized by the government and approved under the MTP Act. In all such places we can go with the MTP. So these are the methods of MTP. In the first trimester up to 12 weeks, I mean up to 4 weeks now, and in second trimester 13 to 20 weeks. These are all methods. Medical methods, we can go either with a mifepristone depending upon the gestational age, or we can go with a combined dose, that is mifi and misoprostol, and methotrexate and misoprostol, and tamoxifen misoprostol. All this can be used for a termination. And next is surgical methods. Menstrual regulation, vacuum aspiration, suction evacuation and curettage, dilatation and evacuation, in all these can be done. In second trimester, we'll go with the prostaglandin analogs, and then surgical methods will be dilatation and evacuation, or intrauterine installation of hyperosmotic solutions like urea, hypertonic urea, saline, and ethacrydyl lactate, or oxytocin infusion, hysterotomy. All this can be done. So surgical methods, menstrual regulation, it is nothing but aspiration of contents of the uterine cavity by means of plastic cannulas, that is Carman's cannula. The syringe, it has 50 ml syringe. It creates a vacuum of 65 centimeter per mercury, and this is nothing but a thumb operated pressure control valve, and it has a piston locking handle. And this can be, menstrual regulation can be done up to 42 days of last menstrual period, that is up to 6 weeks. And next is the vacuum evacuation. Vacuum evacuation, it is the most efficient method of terminating pregnancy up to 12 weeks of gestational age, and this is done by the dilatation of the cervical os can be done by dilators, and then suction cannula is inserted into the uterus, and negative pressure of 65 centimeters of mercury is started, and then we'll evacuate the uterus. And if we are having any grating sensation in the uterine cavity or no further tissue is aspirated, then the procedure is completed, no remnants will be there. And the next is the dilatation and evacuation. MTP up to 16 weeks. It is accomplished by slow and deliberate dilatation of the cervix, and this dilatation can be done with laminaria tents or prostaglandin analogs, and then followed by evacuation of the uterine contents using either vacuum aspiration or aspirotomy with a ovum forceps can be done. In such cases, hemorrhage and infection are the more common. These are more common in second trimester MTP than in the first trimester MTP. And next is the aspirotomy. It involves suction aspiration of the lichen amni followed by evacuation of the fetal parts in pieces, and this is done by aspirotomy forceps, and it is a theatre procedure. First we have to dilate the cervix up to 12 to 14 size of Hagar size, and then amniotic fluid it is drained, and then the fetal can be extracted through the dilated cervix. And coming to the most commonly used drug, that is misoprostol. This is depending upon the gestational age. We'll give, if it is for a pregnancy termination less than 13 weeks, then we'll go with 800 micrograms of misoprostol. And if it is a missed abortion, we can either go with 800 or 600 every third or 3 hourly. And if it is incomplete abortion, then we'll go with the 600 or 400 micrograms. Either these can be given per oral, PV or buccal. If it is 13 to 26 weeks of gestation, then we'll go with a if it is 13 to 24 weeks, then 400 micrograms. And if it is 25 to 26 weeks, then we'll go with the 200 micrograms. And if the fetal heart is not there, that is the fetal death is there, then we'll go with the 200 micrograms per vaginally, sublingually, or either buccal route. Every 4 to 6 hours we have to repeat, and the maximum dose will be up to 6 doses. Inevitable abortion, then we'll go with the 200 micrograms either per vaginal, sublingual or buccal. Every 6 hourly it has to be repeated. And if it is a 26 week, more than 26 weeks of gestation, if it is a pregnancy termination, we'll use 200 micrograms in up to 28 weeks, and if it is more than 28 weeks, we'll go with 100 micrograms. And these are all about PPH management. So this is the methods. In a first trimester, prostaglandin medical management, prostaglandins can be given and mifepristone can be given, or surgical menstrual regulation and vacuum aspiration can be done. In a second trimester, medical management will be either mifi or misoprostol combination can be used, or cerviprime gel, that is prostaglandin F2, I mean E2, and prostaglandin F2 alpha can be used, or intraamniotic, extraamniotic instillation of ethacrylene lactate can be done. These are all the medical methods which are used in second trimester. And next, a surgical procedure, it is a dilatation and evacuation, and aspirotomy can be done in a second trimester. So this is all about abortions and its management. If you are having any doubts, you can ask me, or we'll close the topic.